end malaria indeed this time. All right, so if you're behind, please let's make our way to the front. And also our senior professor, he's called the father of medical laboratory sciences. I want to inform you that MedLab started in Rivers State University, and those that started it in the States, one of our fathers is here. He's no other person but Professor S.D. Abbey. Please let's celebrate our father now. Welcome, sir. Thank you for honoring our invitation. You're welcome, sir. Please, also, as the dignitaries keep coming in, we'll be recognizing them and, of course, celebrating them. They are all at the forefront. This room is filled with people that have contributed to the malaria fight. It is a colloquium of healthcare professionals around this particular disease. And we'll come here to stir up conversation, discuss, and see how we can stir up conversations and make plans on how we can end and implement programs that would end malaria. So on this note, I would like to welcome you once again to this wonderful program. And for coming a little bit late, please celebrate yourself. Let's celebrate ourselves. It's an African thing. We hope to end that kind of character. All right, so if you're behind, come to the front. And we in your program is, in your book, the workshop material is the program. On the first page, you see the lineup of the program. And we'll have a wonderful special MC that will be introducing Hello. All right, thank you very much. Please, can I have some volume, please? Can I have some volume, please? All right, so we'll be having your programs there with you. Within the program, on the first page, is the lineup of the program. And I'll be introducing the MC as we introduce them.
As local helpers, health workers, and it's easier when you have someone you know within the community come to talk to you about something and convince you about something than you have someone else coming from somewhere to try to convince you about the thing. And so when we have some of the community workers trained as health workers, and we try to get the leaders of those communities involved, train them, hold meetings with them. Once they have a proper understanding that what they're going to be doing or the program that is coming there is for their own benefits, I tell you, there'll be a buy-in. But sometimes what really happens is that you will take a program to a community without a proper assessment of their needs. We must know what their needs are. Sometimes it means actually engaging them with some bit of incentive or something. We should do it, because what we're looking at is the bigger picture, is the goal, is trying to see how we can have a buy-in. We should know that some of them may not be on the same page as we are, so we should actually see how we can tailor them to what they are. Because over time, the challenges that some of these programs have actually had has been sometimes access to healthcare, logistics, supply chain. When you even have programs and you want to provide anti-malaria drugs to some of these community people and all that, the flexibility of them having these drugs are not very readily available. They will go to those facilities and not get them. And sad to say, sometimes, even when they get there, these drugs, some of them have been expired because they've been stopped for a very long time, and all that. And so you may not actually have that kind of effective training program that you are looking at. And then we should be able to, when we listen to them and know what their problems are, like I said, having done our needs assessment and we know what their problems are, we'll be able to address those problems from where we can, whichever way we can, and all that. And try to see how we can break whatever religious bias, cultural bias, or whatever it is that will actually hinder the program or cause a bottleneck to the malaria control program we want to have in that place, so that we would decrease any form of acceptability of that program. So those are some of the strategies we can actually have to see how we can have very effective malaria control programs in our community. It will not be fair for some of us to go and initiate a thing and promise we're coming back to those communities and probably never go back, or promise we're going to give them incentives or whatever it is that will have them have a buy-in, or trying to engage those people that we feel we should engage. When you do that and they see themselves as going about monitoring, giving us feedback, because you actually use those feedback to improve on the program in any which way that we can do to ensuring that we achieve our goal. So that's how some of the ways we can have, the health workers can actually have a buy-in of the communities. And the second question said,
beside regular mosquito nets, and
okay,
what other strategies
okay,
can to prevent the spread of malaria?
Okay. Yes, we have also mentioned that some of the easiest things the communities can actually do is taking care of the environment. These mosquitoes and all that have their breeding sites around us, stagnant water, deaths and all, those are things that they can do, for free, and if they're not properly educated, like if you go to most of the communities, they have plantain farms and all that. These places are very breeding sites, and I don't know why somehow the plantain farms are synonymous with where they dump deaths. They go to some of the communities, put their bins there, and all that. So if we educate them properly, that if they take care of their environment and keep them clean, we've solved half of the problem already. So, and then of course the insecticide nets are there, but we must teach them on how best to use these nets. Besides that, the indoor spraying, the African species of the Anopheles mosquito is reported to have more of its impact indoors, biting at night and all that, because we're told that there are over 400 species of the P. falciparum. So if you teach them, because some of them say if you come and you spray inside and all that, the next thing you won't be able to breathe and you'll be able to, and all sorts, they have all sorts of, myths and all that. So if you're able to educate them more on indoor respiratory spraying and all that, then we should be able to help to educate them on how best they can prevent or transmit this malaria we're all talking about now. And maybe even typhoid, what they call typhoid as well. Thank you.
Wow, that's nice. Bitroko, you've done justice to these questions. Thank you very much. Going back again to pharmacist Dr. Obiajuru, double barrel question too. As a pharmacist, we're talking about interprofessional collaboration here now. Collaboration between the pharmacist, the doctor, and the medical laboratory scientist. Now, in terms of drug resistance in our communities, how can you foster a collaborative effort in monitoring drug resistance patterns in our communities? That's one barrel. The second barrel is as it affects access to effective drugs. What strategies can you put in place to improve access to effective anti-malaria medications in our communities?
Thank you. Okay, so for the implementation of collaboration, like it has been already said, collaboration is key between the medical doctors, the pharmacists, the med lab scientists to help reduce this menace of drug-resistant malaria. And this can be done by, the medical doctors already have their own documentation. Med lab scientists have their So the documentation actually helps the tracking of the patterns of this drug resistance we are talking about, both from the end of the physician and the end of the med lab scientist. But for pharmacists, a lot of times we do a lot, but many times we don't have the time, or we say we don't have the time to document. And like they say, what is not documented was not done. So without that documentation, you may not really be able to track the pattern of drug use, the pattern of drug resistance in the patients. So we are encouraging more pharmacists to document. That way, when we set up referral systems, either referral systems to the physician, maybe to a private hospital or to a government hospital, or referral systems to a medical laboratory, that way, at some point, we can all pool our data together to be able to track the way drug resistance has been within that community, or the rate at which malaria medicines have been used, and the pattern of use, the pattern to which these malaria medicines are now becoming resistant, mosquitoes, or rather the malaria is now becoming resistant to most of the malaria medicines and all that. So like for some, I know some few pharmacies have already started it. Some of them have partnership with some medical laboratories already, where when a patient comes in and the person has some certain symptoms, and you really need to clarify if it's malaria or something else. Because like has already been said, malaria symptoms can also be symptoms of a host of other illnesses. So for that clarification, a referral can be sent to a lab within that community for the patient to run a test to be sure that it's actually malaria that the person has. Then also, in cases where it now goes beyond what can be treated within a pharmacy, like the very severe resistant malarias, or when it becomes complicated malaria, then a referral to a hospital has to be done in that particular instance, where the patient will need to be closely monitored while on admission and while the treatment is ongoing. So documentation, like I said, is very key for us to be able to have proper collaboration with other healthcare professionals. Then also, I think NGO partnerships would also be needed. If NGOs are able to be brought on board and they can partner with these three health professionals we have mentioned, the physicians, the pharmacists, and the med lab scientists, to be able to get these effective malaria medicines at a more affordable rate for these patients, then that collaboration will help to get the medications, the effective medications, to the low-income people. Now, I'm linking my response to the next question now. Yes, access to low-income people, how they can get effective medications. So we need that collaboration. We need the NGOs, we need the government to come in. Government can subsidize, or if possible, make malaria medicines free for these low-income areas. So that way, you can actually be sure that whatever is going to those areas is actually effective, and they can get it at low cost. Because we know right now, medicines are quite on the high side in the country. The way everything is going up, that same way medicines are going up. So sometimes you're actually boxed in. When you want to give somebody malaria medicine, you're boxed in. You know that, okay, I can't really trust the source of this medication. But because of costs, you may have to just give it out. So if we can get those very good ones and the effective ones at a subsidized rate through the partnership with NGOs, governments, and other parastatals, then we can be very, very sure that the low-income areas can actually get good access to good medications. Then another way, too, that can also help is, like I've mentioned before, a lot of people that are not trained to handle medications are handling these medications. And you know that when somebody is not trained, you don't know what the body is doing to the drug. You don't know what the drug does to the human body. You don't know anything. All you know is that, okay, I trained somewhere. They say the drug, they treat malaria. Then they use that and treat malaria and typhoid. Then they use that and treat this and that. And you keep giving it out to people without realizing that this drug can become a potential poison to this patient, or realizing that there are certain things you look out for when you're giving medications. So if we are able to put in processes where we are sure that people who are actually licensed to handle medications, to provide the proper counseling, to provide the proper pharmaceutical care important to these patients, are actually in these low-income areas, like the rural areas and all. Like example, there was a time the satellite pharmacy thing was established, but I don't know if it has been, I'm not too sure if it has been implemented. What that means is that a registered pharmacy within the city can actually set up a branch in the rural area. And that way, you can be very certain that the person who is manning the place is actually a trained pharmacist and all that. So you can be very sure that the medications that will be sent to that low-income area would actually be very, very good drugs. Thank you.
Well, thank you very much, Obiajiru. It's a good one. Now, I'm aware that, that's to Dr. Mina. I'm aware that in all our health facilities, all the primary health care facilities, there is free testing and free treatment. And so you see our state has done so much. River State has done so much. But the challenge is this. I go to my community. I'm from Okrika. I get to Okrika now. I'll show you part of the things I see there. When I get there, of course, Dr. Abiye don't come. People will come to meet me for cases as simple as malaria. And so the concern I have is, but these services are provided in all the health centers all over you. There is one near you here. Go to Ayungupuri, you have there. Go to so place, there is one there. Go to Goloma, you have. So why meet me for this? So it's a major thing of concern. Those services are provided there, but the people are not aware. So how do we encourage the same buy-in I talked about here? How can the communities buy in? How can they own? What measures can we put in place that the community take ownership of these health facilities, and so the people now know the type of services that are rendered there, so they can access the free treatment and free testing there. So what can be done?
This is your question. And now, Dr. B.A., they will surely come to you. You're a big man. Let's just, Auntie, if you go to Popo, will they not come to you? Auntie, I want drugs. Some things are given. We live in a society that is very interactive and communal. So whether you like it or not, that you're Dr. Abiye, just have it at the back of your mind. They will come to you. If Betty goes to her village, they will come to her. Executive Secretary, that bag you're holding, that drugs, give us. So we should expect that. Now, Dr. Abiye, what would you do when they come to you? So I throw the question back at you. So it's now in your place. Because like I said, this is not about anybody. This is about everybody now. The people in Okrika are not from my place. So it's you they will have faith in. What you say to an Okrika man, he will believe faster than what me, an Opobo person, would say. True or false? True. So it's for you to say there are commodities in the facilities. Go there. Every fever is not malaria. Go and do your testing. And if you test, if it's positive, they will give you drugs. Are we together? Yes. So I think he has raised a very pertinent thing. It happens everywhere. It's not just in his place. If Linda goes to Bonnie, thank God doctor don't come. Bring that your bag. You'll have drugs. Is it not so? So for us, we need to become intentional. This is not just about the government. There's how much government can do. when you become an adult, for you to change your mindset and your perspective, do you know you need to hear the same message for 66 days consecutively? So the BCC cannot even do that. That's a behavioral change communication team in the ministry. I can't go to Okrika for 66 days. Take it out. That's 3 months. Bros, what's happened now? When you're there. So it's for you. You know the stakeholders. You know the people that are the gatekeepers. You know the people that everybody listens to. Women leaders, youth leaders. Pass the message you know and tell them. And that way, honestly, we are going to see this change we so desperately want to have. I'm just using his name because he has called. And that's why the same applies to you. Mama Jack, everybody sitting here is basically the same. Let us be our storytellers until the lion can speak and begin to tell his story. The hunter will always look like the victor. True or false? Good. So if you don't begin to tell your story, nobody will tell it for you. You tell your story in a half and join manner. By the time they repeat it, it will be quarter and join. So tell the full story. Go to the facilities. You will see commodities. There are plenty. Don't stay till these commodities expire. It's not good for us. Because if they do, we won't get again. So please, let us tell the story the way we should. Thank you.
Sorry, medications, not commodities.
Thank you. Yeah, I know. Dr. Bitorka wants to say this, but I'm seriously, before you go, it's actually a teaser I posed to her. Yeah, they will come to us, but she has answered it. We need to take it up. Government can't do everything. These are some of the things she has said here. I intentionally brought this up. You know, we are all critical stakeholders. When we get to our communities, we should meet these opinion leaders, those, like you said, the gatekeepers. Let the people be aware. Let them own the facilities. Let them know the kind of things they do in the facilities. Let the people know what they can access from these facilities. Those things are provided there. So if we take it up, we will change the dynamics. So,
Okay, quickly, in addition to that, I think one of the things we can actually do too is to have a very effective communication channel. By that I mean, like, before now we used to have our news broadcast in our local languages and all that. So we can actually partner with media houses and see how we can translate some of these informations through local languages and all that. And then within the communities as well, we have leaders that can actually be engaged, so that they engage the town criers, you know, and all that. So the media, the channel, the communications, it should be more robust now. You know, we just keep doing it. Even the religious book says that faith cometh by hearing it every now and then, again and again and again. So we won't stop. We just keep talking and talking through any form of means, any channel, and make sure that we can pass the message. Thank you.
All right, thank you. At this point, the talk has been this way. I want contributions. Okay.
Okay, let me just say this. I think Dr. Abie brought up something, so we'll still speak to it, because this is very important to us as a ministry. It's important to His Excellency. It's important to the Deputy Governor, the Honorable Commissioner, and indeed the entire Ministry of Health, the health. We have commodities in the facilities. When I say commodities, I include IEC materials. There are lots of them are in the facilities. We have RDTs, we have ACTs, we have ALs, we have SPs, we have IEC materials, we have gloves, we have what's it called now? Waste bins, and so on. A lot of things have been sent to the facilities. We even have SOPs. We have case management modules in the facilities. Yes, ma, we do. Those things were sent. I think the last delivery was done 2 weeks ago. So every facility, almost every facility has these things, except there is no room for storage. then you take the nearest one and you let them that you are the surrogates for this one. So if you want something, there's no storage here. Just scared not to give them because of storage. So we go to the nearest place and we give. So let everybody know that these commodities are free. Go and pick up IEC materials. Some are in your dialects. Yes. So if you don't do it, we are expected to replenish these commodities in the next 6 months. So if these commodities have not finished, will they replenish for us? No. But trust me, do you know the North? They finish their commodities. They are replenishing the second and the third and the fourth. Speaking to what she said, we have one of the things we have developed is a grievance redress mechanism. So if you go to any facility and they try to sell drugs to you, anti-malarials, or they try to make you pay for the test, see numbers there. This facility is a GRM-friendly facility. In other words, a grievance redress mechanism facility. So tell your people that numbers, if they go, they should look out well. Call those numbers. Tell them that selling the drugs to you, they will quietly come and address that, and you get your drugs free. You get your testing free. You get your IEC materials free. Thank you very much.
Sorry, quick one, ma. You mentioned waste bin as part of the commodities. So they're actually meant to be given out free to those in the communities too? Oh, right. That's a good one.
All right, so for
all right, so question. The first contribution.
Snappy, sir.
Thank you. My name is Pharmacist Chima Obu, past leader of the pharmaceutical sector in Rivers State. I can see all my beautiful friends here. Thank you, doctor. You almost took the word out of my mouth. Dr. Mina Jajagogo, I thank you for being physically present, because you are going to take this message back to the state government. We live in a multilingual society in Rivers State with over 28 languages, indigenous. And globally, the issue of collaboration has been challenged mainly by seamless communication. Bringing it down to the state level, where you have a multilingual society, please, I want to ask, what deliberate efforts the ministry is making to ensure that the communication between the providers, the professionals, and the receivers, the community or the public we are serving, is seamless. We must have a pattern of communication, because communication remains a major issue in collaborative efforts all over the world. Please, what are the steps you have taken to address this in the state? Thank you.
Okay, thank you very much, sir. And presently, we have 23 focal persons who are indigenous to the LGAs they come from. In other words, in Bonny, we have Belema. She's Bonny, born, bred in Bonny, speaks Bonny fluently. She can take my message in the most simple terms to the market woman in Bonny, and the market woman will understand what she's saying. And we also have a platform for that. We call it the Malaria Focal Persons. So for every time they go out and are doing this communication in the local dialect, in the way the people understand, they take photographs and they send to us. They do videos and they send to us. So we have a feedback. So depending on the feedback we get, we send that same feedback to Abuja, the National Malaria Program. So when you're preparing documents, this set of people, we have more people here that are listening more. Please kindly do more documents in this language. The second thing, we also have another set of 23 people. We call them the focal Akomin persons. They are the ones implementing in Rivers State. In fact, we have 2 focal persons per LGA for ACOMIN. So they also go, it's like a door-to-door thing. I call them my soldier ants because they're everywhere really. They go end to end. Sometimes they don't even let you know that the ones. You wouldn't know that they're working for the ministry or for the malaria program. They engage you, they ask you questions. Are you satisfied? Oga, what these people are doing? Are you happy? Are they doing well at all? What do you think they can do better? And then you begin to talk. And you don't know that they are recording what you're saying or they're listening. And immediately you're done. They give us a feedback. They put the person's name. They may even take a selfie with you. So when you see people talking to you a lot about malaria and doing selfies, those are our focal persons. So we are very intentional about getting feedbacks. We also have suggestion boxes in all these facilities. What you don't like, put in there. What you suggest, we do better. Because like I said, it's a learning, we're unlearning, we're relearning, as it were. What you think we could do better, write in the suggestion box. At the end of every quarter, we take all the suggestion boxes, we open, we look, and then we try to merge all the thoughts and then actualize it in conversation and in action. Thank you. I don't know if I've answered your question. Thank you, sir.
Good afternoon, everyone. I thank you so much. You all have done greatly and enlightened us the more. And from all you said, as she was talking about the gatekeepers and almost all of you, and reaching out to our communities. But I want to, it's just a suggestion, that it's good sending people there that are representing the ministry, people from there, born and bred. But I want to, especially to the representative of the Rivers State government, this program you have, we are all collaborating to work together. I'm sure some have long-term, and others have short-term programs. I want to plead that if you can involve the chiefs, we all know that in every community we have chiefs, we have youth leaders, we have people that lead the people. If you can bring them, invite them over, let them be part of the planning. Let them have it in their own schedule. That's so time. In every family, we know that during Christmas they do meeting. Easter, they go to meeting. Is it not right? These are all scheduled meetings for families. So when they go, they are not just waiting for people to come to them. They will have them in their diary. She said you can give them incentive. Do them well. So they will not carry this on their head. Anytime they are converging for their family meetings, worry meetings, community meetings, it is going to be part of the agenda. It could be 4 monthly, 3 monthly. So that by the time they tell them from their little families, their worries and so on, when the other people coming from outside, they go to pay homage. They already know because they have owned, they are part of the government. They know that this is our program. That is all I want to say. Thank you. I'm from Okrika. Thank you.
Thank you very much, ma. One from you ask the next time.
Okay, thank you, wonderful panelists, for all you've said. But I just want to say that I think we are talking too much than we are actually implementing. I know that some years ago, the malaria control strategy was vector control. And I don't know how long and how much this vector control has been driven down, especially in communities. I think if we focus more on vector controls, we will talk less on therapeutics and all these other strategies we are talking about. I think the main focus should be, especially in the rural areas, should be on vector control. And once we get that in the kitty, then it makes these other strategies strenuous to drive through. So I think that especially to the Rivers rep, we should take that message of vector control to the rural communities where that can be driven through. And once we can get that vector control, I'm sure these other strategies will be a lot less to drive through. Thank you. That's my conclusion.
All right. We're done? Okay, wow. That's a fantastic one. Let's give him his time.
All right, thank you so much. Again, I would like to speak to the rep from the ministry, Madam. I think there is need for strong collaboration between the Ministry of Health and Ministry of Environment. Because if we want to make good progress, that means in preventing malaria, our environment plays a very key role. So, I know that you know that I know what you're doing, but for the purpose of this platform, I'm making this advice that there is strong need for strong collaboration between the Ministry of Health and Ministry of Environment that will help in giving us a good result in this fight. Thank you very much.
Hello, okay, let me start from Pharmacist Promise. I think I'd rather not answer you because we're on the same committee. And you know what we've done so far and what we're still struggling to do. So I think you spoke for the benefit of everybody. So everybody has said. Then so, sir, to the fine gentleman that spoke about vector control, I thank you for recognizing that. And the National Malaria Program is not unaware of that. Neither is the state unaware of that. There's still conversations in the pipeline. Recall that we had done larviciding in River State some years back. While you applauded it, a number of people wrote against it very intentionally. We had done indoor residual spraying. We used 2 LGAs as pilot LGAs some 3 or 4 years back. While you said that was good, those LGAs, they wrote strongly against it. So it's one man's meat seems to be another man's poison. So while we are speaking around that table again, that conversation has been resurrected, and thankfully Global Fund is willing to come and help. There are things we also have to look at. Will this be acceptable to the communities? We are at the beginning phase of those conversations. Sooner or later, the chiefs and all the stakeholders in the communities will be called. Because really, for some communities, they will tell you, if you've done IRS, that means you have people to come into your house and spray. Some communities say it's not acceptable. I don't want it. Don't come into my house. You, by the time you're leaving, you'll be eyeing my wife. You'd have started talking to my little daughter. Even the men will be eyeing. No, but it's true. It's true. Those were some of the things they said. And they said, don't come. Because these young men have to come, and it's not everybody. It's really young men between 20 to 32. And you know, these ones have a, So this biceps, 6 packs. So they are, community leaders are just not comfortable with such people. And they have to come into your house today, tomorrow, the next day. And some people say, Mba, it's better the mosquito bites my child than these ones come every day under the pretext of spraying the wall and are talking to my daughters. So there's a lot of back and forth, but we'll get there. Let me leave it that way, we'll get there. Thank you very much, sir, for that contribution. Thank you.
All right, thank you. Thank you, thank you. I'm giving one minute. 1 minute for a closing word. Just 1 minute. Dr. Bichoro.
Thank you very much. I want to say there is new hope. There is hope. I was also laughing at myself when I said we should make communication robust. Some of us here can't even speak our languages. So when we go to our various homes and they speak these languages, becomes a problem. The very common thing I know that is, common to everyone is the pidgin English and all that. So we'll keep pushing and pushing and pushing. And everyone here is a stakeholder. Please, everybody. The communities, when we get back, we all have a role to play. Let's do well and do this and eradicate malaria finally.
1 minute, pharmacist.
So we have agreed that collaboration is key. Collaborate, collaborate, collaborate. Then also we need to do better for our patients. Patient education is also key. We need to find ways to educate them, keep on educating them, and keep on educating them. And also we need to also, like we said, find the gatekeepers in these communities, relate with them, and get them to spread the word on our behalf.
And so Rivers State accelerating the fight against malaria for a more equitable river state. A river state where the people in Bundu Waterside and the people in Okrika Waterfront and the people in down below in Opobo will have the same equitable opportunity. GRA in Port Harcourt. And let's change now. You and change the. Thank you.
On a final note, I want to thank the panelists. Dr. Bichoko, thank you. Dr. Obiajuru, you've done so well. My sister, Dr. Mina, fantastic one. And then to our wonderful audience that took out time to listen to us, get a whole lot of information given, articulated them, and even made contributions. I say thank you, thank you, thank you.
Thank you very much. Please, let's celebrate them. Please, there are certificates for participation. Please, let's welcome Professor Edna Igbegbulem to present these certificates to them as they make their way. And after this, we'll have a goodwill message from Dr. Betty Agala. She's from the state. We need to honor our governor. All right, then, of course, we'll have Mikio for their own goodwill message. So, please, let's welcome Professor Edna Igbegbulem to do justice to that. All right. So, Dr. Abiye, you're the facilitator. We'll send you something. Thank you very much, sir. God bless you.
Obiajuru, Wayemeru, I present you with this certificate in appreciation of your participation in today's event. Dr. Ibitoroko, Maureen George Opuda, we're very appreciative of your participation and your dissemination of your wealth of experience in the fight against malaria. Please accept this on behalf of Erin's Foundation. Thank you very much.
To be the best, number one, nothing less. Lead me to my destiny. I have waited
very dynamic, Tomina Gogo. We appreciate your presence here today and all you have told us about what Rivers State is doing to fight malaria. Please accept this on behalf of the Foundation for your participation here today. And the Association of Community Pharmacists. Thank you.
stand up, stand up, stand up.
The keynote speaker, Professor Kaladada Kurubo, who is ably represented here today by Dr. Dublin Green. We want to appreciate you for your participation in this event today. We say thank you very much on behalf of Erin's Foundation and Community Health Pharmacists.
I have waited patiently. I have vision, though I believe. I know I can count on me. So stand up for the champion.
The next one is an award to be presented to Pastor Scott Irikife. Pastor Scott Irikife. Is he here?
For the champions, for the champions, stand up, stand up, stand up. For the champions, for the champions.
To your impact on the body of Christ, transforming transforming lives and adding value to humanity. Please, on behalf of Erin's Foundation and community.
Here we go, it's getting close. Now it's just who.
All right, thank you so much. Thank you so much. Please put a hand of applause for all our panelists here today. All right, so, I'm coming from a different space. I'm coming from the media space. And in the media, we believe in instant feedback. So I was sitting right there at the back, and for some reason, it seems like the hall is divided. Some people are for, and some people are in between. So let's just be sure that we are all together, especially my brothers and sisters and friends at the back. My brothers and sisters and friends at the back, if you heard at least 2 things from the last panel session, please, can you give me Okay, are we together? Can we see what's going on? Meanwhile, our professors and scholars in front, if you participated by hearing, listening, and understanding everything that the panelists said today, can you give me oh-ho? So, do we see where we are now? So I'm still seeking that we all at the back come forward now. It's not an examination. Come forward and be part of what we are doing today, ladies and gentlemen. All right, so moving forward, we have so many things to learn today. Giving us goodwill message is Dr. Betty Agala. She is the Executive Secretary, River State Contributory Health Protection Program. Ladies and gentlemen, please put your hands together for Dr. Betty Agala. She comes forward. Mikia, please, you are next.
Good afternoon, very distinguished scholars on the front seats and head table. Permit me to rest on the existing protocol. I want to use this opportunity to thank the Erin Foundation, Erin Equipo Health Foundation, for inviting me to this 3rd colloquium. I'm very excited to be here because what hit me in the first presentation was collaboration. And collaboration is not just about talking, it's about action. That's what I have learned here today. And so on that note, I want to bring us greetings from the River State Contributory Health Protection Program. The River State Health Insurance Agency mandated to take River States to the next level on universal health coverage. It might interest us to know that malaria accounts for at least 30% of hospital visitation, if not more, and at least 20% of admissions. And I'm excited to corroborate what Dr. Mina has said concerning free malaria treatment. But what the state governor, Sir Siminalayi Fubara, GSSRS, has done has gone beyond treating malaria. He has ensured that to accelerate the fight against malaria for a more equitable world, that everyone that lives and works in River State can have access to health insurance, to financial risk protection, to health care of sufficient quality without having to pay out of pocket at the point of service. And so yes, malaria testing is free, but what if you're tested and it's not malaria? What happens? You would have to pay for the rest of the services, isn't it? And so I'm here to introduce to us health insurance in River State. Our office is located at the 2nd wing, or the wing A of the 2nd floor, Waterlines remodeled building. It's Block A. We're sharing the space with the Bureau of Public Procurement. You can reach us on our website, on our social media handles, And just as has been said, we're engaging every community. And so we're coming to you. We're going to be engaging everyone, formal sector, informal sector, poor and vulnerable people. We have started enrolling. His Excellency the Governor flagged off enrollment for the vulnerable population on the 11th of April. And so those in Okrika is featuring very seriously, and it seems we don't know so much about the free malaria program. But there's more for you. The free health program of Dr. Siminalayi Fubara is coming to you in Okrika for those who are pregnant, for children under 5, for those living with disability, and the poorest of the poor amongst us. So I want to thank all of us for being here, using our work-free day to be here to talk about ending malaria, because we can do it. Say, I can do it. You have a role to play, just keeping your environment clean, just ensuring that that woman registered for antenatal, just ensuring that that child goes to the hospital for vaccinations, for growth monitoring, and the child's immune system is good. You can do something to ensure that we have a malaria-free world. Thank you so much, and do have very fruitful deliberations. Thank you.
Thank you so much, Dr. Agala. Thank you so much. And so re-emphasizing the keyword for today, collaboration, something about collaboration. So can we do it? Let's hope we've not forgotten. Do we remember our action word for collaboration? So turn to your neighbor and let's go. Turn to your neighbor, turn to your neighbor, turn to your neighbor. You know, of course, we go 1, 2, ready, go. What is happening now? Must we feel it first? Especially our back people. And you're just coming, so you don't understand. So this is our action word for today. So we have agreed that we will all work together. So we'll face ourselves, and at the count of go, we all hit 5, screaming collaboration, because we believe we will all collaborate. So are we ready? Let's take it again. 1, 2, ready, go. Yes, I'm still collaborating. We have MeCure Pharmaceuticals. Please put your hands together for MeCure Pharmaceutical Limited as they come forward for their presentation. Thank you. Put your hands together for them. They are here.
Thank you. Moderator. Good afternoon, everyone. Be here this afternoon. My name is Tony Iron. Cure Industries Limited. ACPN. Actually, to be around for this meeting, but for logistics, last night I was made aware I couldn't get a flight to Port Harcourt. So I'll be standing in for the chairman, MeCure Industries Limited. Okay. Some weeks ago we had, I think it was with the ESCO, ACPN ESCO in Abuja, we introduced our scheme, fake and counterfeit drugs in Nigeria. And today I'll be playing this video where you see what we've done using technology to fight against fake and counterfeit drug in Nigeria. And also after the video, I'll give you a brief history on why MeCure as a company decided that it's important we take this route to fight fake and counterfeit drugs in Nigeria. Now, there was a statistic released in 2021 by the Bayero University, and a study they did, and it showed that 41 to 50% of drugs in Nigeria are actually fake. And now when you look at the implication of this, when it comes to healthcare implications, this is significant. And the issue of fake and counterfeit drugs is a global monster. It's not only in Nigeria. It was done in 2023, and it showed that for every 1 hour, 57 persons died as a result of use of fake drugs in Nigeria, in sub-Saharan Africa. Now, I'm talking about mortality now. I'm not talking about other implications. I'm talking about mortality. For every 1 hour, 57 persons died as a result of fake drugs in sub-Saharan Africa, outside the economic implications and others. Now, I'm going to play a 2-minute video to show what McCure as a company is doing in collaboration with NAFDAC to use technology of in Nigeria. So after the 2-minute video, I will come and explain and actually practicalize what we are actually doing and partners when it comes to fighting against these fake and counterfeit drugs in Nigeria. Can you help me with the video here? Okay. The volume is not coming on, so maybe I will just... Okay, give me a pack. Let me just...
become the sentinels of safety, ensuring that each medicine that reaches the patient is genuine, safe and effective. McCure's Point End Pocket Incentive and Loyalty Program sweetens the deal. It rewards pharmacies for their active participation in ensuring genuine medicines through QR code scans. It's not just about incentives, it's about making every stakeholder a part of the solution. It's about contributing to pharmacovigilance and post-marketing surveillance efforts. The future implication isn't just a program, it is a weapon in the fight against to cure, becomes a harbinger of harm. This is not a dystopian fantasy, but a stark reality for Kunle, a patient who fell prey to the perilous world of counterfeit medicines. His story begins with an innocuous headache, a simple over-the-counter drug, and ends with a life-threatening condition. Kunle's story is not an isolated incident. Indeed, counterfeit medicines are a global menace, a silent epidemic causing untold harm to countless unsuspecting patients. But there is a solution, a beacon of hope in the form of McCure's Track and Trace program. This revolutionary system is a game changer, a knight in shining armor. It ensures the authenticity and traceability of pharmaceutical products from production to retail, establishing a serialized parent and child relationship between products of the same batch. This ingenious system enables the movement of each pack to be captured and recorded at every step of the supply chain. Track and Trace is more than just a program, it is a weapon in the fight against counterfeit medicines. It's a guarantee of quality control with a single click. High-quality clinical cartons imprinted with QR codes become the sentinels of safety, ensuring that each medicine that reaches the patient is genuine, safe and effective. McCure's Point End Pocket Incentive and Loyalty Program sweetens the deal. It rewards pharmacies for their active participation in ensuring genuine medicines through QR code scans. It's not just about incentives, it's about making every stakeholder a part of the solution. It's about contributing to pharmacovigilance and post-marketing surveillance efforts. The future implications of such a program are immense. It's not just about ensuring the authenticity of medicines today, but about shaping the pharmaceutical industry of tomorrow. It's about creating a world where every pill is a promise of health, where every medicine is a symbol of trust, where every patient is assured of safety in in this world there will be no more stories like Kunla's, no more patients suffering due to counterfeit medicines, because in this Nigeria, every medicine of Mercure is tracked, every medicine is traced, and every medicine is authentic. This is the power, the promise, and the potential of Mercure's track and trace program. So as we step into a future of innovation and authenticity, remember it all starts with one click, one scan, one step towards ensuring the safety and well-being of patients all over Nigeria. This is the power of Mercure's track and trace program, a program that is not just about fighting counterfeit medicines, but about ensuring a future of health, safety, and trust. This is the future of the pharmaceutical industry. This is Mercure. Let's make healthy Nigeria, my Nigeria.
Five containers of one of our products.
And Juliet Anibo, she's representing Sam Pharmaceuticals Limited. Please put your hands together for her as she comes forward. Are you tired of clapping? Thank you.
Good morning, all. Good morning. I welcome you to this prestigious event. Please permit me to stand on an existing protocol. I am, as she is formally introduced, Dr. Nkem Juliet Anibo from Sam Pharmaceutical Limited. Before I go on, I would like to introduce my company. The Sam Pharmaceutical Company is an indigenous company that has been in this country for over 53 years. And we are known for producing, marketing safe, reliable, and quality pharmaceutical products. I'm here to introduce a very wonderful drug that will bridge the gap to consistent relapse to malaria epidemic. It's very efficient, it's very safe, and it has been tested, proven, and trusted. But before we go, I would like us to have a look about 5 parasite species of this parasite. And 2 are very paramount, especially Plasmodium falciparum and Plasmodium vivax, which pose the greatest fever, chills, flu, illness, and if left untreated, they may develop a severe complication and death might result. A malaria country, the most dangerous. Yes, we know. Country, the most dangerous. Yes, we know. That even there has been an increase in malaria incidence and mortality rate has also increased. And Nigeria is the most vulnerable in the sense that the children or the immune-compromised patients and the older ones are mostly affected, plus the pregnant women. What is the good news I have to say? The good news I brought here is that this infection is treatable, is preventable, and is curable. In Nigeria, we know that we use ACT-based therapy, which is the first-line anti-malaria medicine for uncomplicated B. falciparum malaria in all population, including pregnant women in their 2nd and 3rd trimesters since 2023. Why ACT? Because they are mostly rapidly acting of all anti-malaria drugs and produce the fastest clinical responses by reducing the number of parasites per asexual cycle. And they are also highly active against all Plasmodium species. What is the big question here? Are all anti-malaria truly anti-malaria? Are all 8480 truly 8480? Are all 2120 truly 2120? I present to you the anti-malaria that really works. The anti-malaria that has been tested, proven, and trusted And when you use it, I will testify to you that you will be happy a product of our prestigious company. Thank you for your apt attention. Thank you so much.
Thank you very much, ladies and gentlemen. I believe we're having a wonderful time. Please don't be in a hurry to leave because lunch is being served very soon. So don't rush. As I said, we have able men that are ready to do that. We'll be going to our next panel session. But before that, let me my own professor. And she has done very well around the public health space.
To be the best, number one, nothing less. Lead me to my destiny.
Very much. Thank you very much. All right. So at this point, we'll be going over to our next session, and I would like my Oga, my brother, our senior in this business. Please let's welcome Dr. Abiye. That's MedLab Science started from Rivers State University, formerly Rivers State University of Science and Technology. And these are the fathers of MedLab across Nigeria. And he's here, hale, hearty, and alive. We celebrate you, sir. Let's celebrate him once again, Professor S.T. Abe. God bless you, sir. At this point, let us have the citation of our first panelist. As they make their way, the citation will be done, and the award or the certificate will be presented, and they get to sit down. Let's welcome to represent Dr. Rhoda Walozie, Dr. Chidima Azike. Your hands together as she makes her way now. Your hands together as she makes her way.
A brief citation of Dr. Rhoda M.E. Walozie. Dr. Rhoda M.E. Walozie obtained a PhD in medical microbiology at the University of Port Harcourt and a master's degree in public health at the Global Wealth University and the South American University, respectively. She has a master's degree in medical microbiology from the River State University, Port Harcourt. She also has a master's degree in environmental management from the Imo State University, Owerri. She's a fellow of medical microbiology and an associate in parasitology, Medical Laboratory Science Council of Nigeria. Dr. Rhoda Walozie is a senior lecturer and researcher. She's skilled in medical microbiology and parasitology techniques, a multidisciplinary and scholarly scientist, public health scientist, and advocate. Dr. Rhoda is a biorisk management trainer, and she's also a neglected tropical diseases and Laboratory Society for Microbiology, Nigeria Society for Microbiology, etc. Dr. Rhoda is a facilitator, mentor, and member of committees in organizing conferences at local, national, and international levels. She has received numerous outstanding awards. Dr. Rhoda M.E. Walozie is happily married and has adorable godly children. Ladies and gentlemen, please help me make welcome Dr. Rhoda M.E. Walozie.
And to present this certificate is the chairman of Association of Community Pharmacists, River State Chapter Pharmacists. Second will be a tech guru. A tech guru, I hope he's here. A very young man and a tech guru. Please let's welcome Mr.
Adaora Patience Ouka. Dr. Adaora Patience Ouka is a Deputy Director, Medical Laboratory Services, working with the University of Port Harcourt Teaching Hospital, Alakaya, River State, for over 20 years. She is also an active fellow member of the AMLCN, a member of the Association of Female Medical Laboratory Scientists of Nigeria, River State Branch, an Honorable Director of the Guild of Medical Laboratory Directors of Nigeria, a fellow and active member of the Institute of Biomedical Sciences, London, a registered member of the Healthcare Professional Council, London, a fellow member of the West African Postgraduate College of Medical Laboratory Science, Faculty of Bacteriology. She has a doctorate degree in medical microbiology and parasitology. Her area of research interest is on molecular characterization of antibiotics-resistant genes in clinical isolates. She has over 25 publications in international journals. She is a registered member of the International ORCID community, a member of the Nigerian Society of Microbiology, a member of Parasitology Microbiology and the Public Health Society of Nigeria, Nigeria Biological Safety Association, and an active member of the Organization for Women in Science and Development. She is happily married to Professor Francis Anacletus, and they are blessed with 4 children. Ladies and gentlemen, please help me make welcome Dr. Ada Ora, Patience Onwuka.
Thank you very much. And to present the certificate of appreciation, please let's welcome Pharmacist Bridget Otote, FPSN. Your hands together should meet somebody now. Let's celebrate her.
It's getting close. Now it's just who wants it most. It's just life, that's how it is. 'Cause we have our strengths and weaknesses. Oh, I have vision, oh, can't you see? I'm on the move, make way for me. So stand up for the champions.
The certificate of appreciation as a panelist presented to Dr. Adaora Patience Onwuka at her 3rd annual health colloquium, Uniting Forces. Team Uniting Forces Healthcare Collaboration for Zero Malaria in Rivers State, Nigeria. On this day, 1st May 2024. Congratulations, madam.
Thank you very much. Let's celebrate them now. Thank you very much. So now you make your way to your seat. And of course, I'd like to welcome a young doctor of philosophy, very young man, and he's also my friend. Please let's welcome Dr. Solomon. Please your hands together to make his way.
Recitation of Dr. Solomon Ikechi Ogbonna. Dr. Solomon Ikechi Ogbonna is from Obakri in Amoha local government of Rivers State. Born and raised in Port Harcourt, he attended Ojims Primary School and Government Comprehensive Secondary School, where he obtained his first school leaving certificate and senior secondary school certificate respectively. Solomon Ogbonna earned a bachelor's degree in microbiology from Rivers State University of Science and Technology, now Rivers State University. He went on to earn a master's degree and eventually bagged a PhD in public health from Rivers State University. He's a lecturer in the Department of Microbiology, Rivers State University, and has several publications to his name in internationally renowned journals. He is a member of several professional bodies, including Nigeria Society for Microbiology and Mycological Society of Nigeria, a pioneer team member of the World Bank-assisted Rollback Malaria Program for RSU, USAID-funded biolabiciting and indoor residual spraying team for River State, and the Bonny Malaria Elimination Project funded by the NLNG. Amongst other things, he is a politician and a public affairs analyst. Ladies and gentlemen, please help me make welcome Dr. Solomon Ikechi Ogbonna.
Thank you very much. And to present the certificate of appreciation will be our own Professor S.D. Abe. Let's celebrate our father now.
Thank you very much for the opportunity. Mr. Dr. Solomon, we hear you're a politician as well. You have no place here then. Collaboration, thank you. That is the word. Yes. This is a certificate of appreciation as a panelist at her 3rd annual health colloquium, Uniting Forces Healthcare Collaboration for Zero Malaria in Rivers State, Nigeria. On this day, 1st May 2024, at this renowned resort in Port Harcourt, GRA Phase 2. Congratulations.
Let's celebrate our father now. Thank you very much. And also to join them on the podium is a tech guru. He's also my friend, a wonderful tech man. And it's good we see how the future goes from here. Everybody's going tech. So let's see how we bring that dimension into the scheme of things. Let's welcome Lucas Bruce. Your hands together as he makes his way and as we play his citation.
A brief citation of Mr. Lucas Bruce. Mr. Lucas Bruce, MNCS, ACFI, CCWP, founder, CEO of Alotu Square, a certified computer forensic investigator, a Cambridge certified web publisher, and an International Business Management Institute certified innovation manager. He's a professional manager of the Nigerian Computer Science and the Computer Forensic Institute, Nigeria. He is a mentor to developers, startups, and entrepreneurs. He is also the founder of Lena Hosting Solutions, a web hosting company, and most recently a co-founder of GeroCare Solutions Limited, an online hospital that provides medical services by verified doctors to the elderly at the comfort of
Adewale. Please let's celebrate him now.
It's my honor to of appreciation to Mr. Bruce Lucas at the 3rd annual Colloquium, Uniting Forces Healthcare Collaboration for Zero Malaria in Rivers State. Congratulations.
Malaria in Rivers State and beyond. Thank you very much, and I'll move over to my senior and our facilitator, Dr. Apiye, for his session. Thank you, sir.
Thank you very much. To the second session. And if as possible, I'll start with Dr. Chideba Azike. Your area of focus is combating social and economic barriers as it affects addressing poverty, malnutrition, and limited access to clean water and sanitation as major contributory factors. In specific question, in your experience, what specific social and economic barriers create the most significant challenges in tackling malaria transmission in the Niger Delta region? And what possible interventions can be designed to address these barriers effectively?
Thank you very much. That is a good question to start with. In Niger Delta today, we must agree that there are a lot of factors that serve as barrier in tackling malaria. And one of them is inadequate access, lack of access to health care and even health, especially to rural areas and remote areas. This year we are celebrating World Malaria Day. And if I'm not mistaken, here in Port Harcourt, which is an urban area, activities like this, we had about 3 or 4. I was a witness yesterday in Rivers State University. But I doubt if there is any of these organizations planning such activity or events in interior areas like the villages. So this is one of the barriers in ensuring that we tackle malaria. Then secondly, there is insufficient fund. Yes, government is trying their best to ensure that we tackle malaria and reduce this to nearest minimum, or if possible, eradicate it entirely. But then, fund is not enough to, treat malaria and even carry out interventions to ensure that malaria is reduced to the barest minimum. There's also this cultural and traditional factor that affects the malaria prevention. Most persons believe that it's better to use herbal remedies and other
homemade remedies to tackle malaria. So in that case, you see are affected, the vulnerable individuals find it difficult to have access to health care. They do not have enough money, even when tested positive. They do not have enough money to even purchase anti-malaria drugs. They do also have money to even buy nets, treated nets. So, and because of poverty too, people find themselves living in an overcrowded environment. The housing is in a very poor condition. So, and such case, it becomes...
You've highlighted the problems. Part of your question is also telling us the strategies you put in place to tackle these problems you've highlighted. What strategies will you put in place?
All right. As I mentioned, one of the problems is lack of health education. If what RNSP Foundation is doing today in collaboration with pharmaceutical society or community in Port Harcourt can be taken down to rural areas like Andoni, Boni, those villages that no one is even planning to go, maybe because you need to cross water. If they can take it there, it's a good strategy. Secondly, if government or other NGOs, even pharmaceutical societies, can arrange and get some anti-malaria drugs and send it to villages and ensure that vulnerable populations have access to this drug, if not for anything, at least at minimal cost, so that both poor and rich can can purchase these anti-malaria drugs. That is also another good strategy. Then, it's important that we keep enlightening community members, the men and women in the villages, that not all headache is village witch hunting them. They should ensure that they get themselves tested and be sure that it's malaria that is the problem, and even other root cause of their diseases. They should be tested all the time before they take anything. Some persons are fond of any small headache, any form of ill condition. There is always this herbal concoction in a bottle that is curing every disease. So they keep taking it no matter the condition. So they should be enlightened that they need to go to hospital, they need to be tested, they need to know what they're treating, they need to know what they're taking, and ensure that they don't take these herbal drugs. They don't, in fact, the problem is that this herbal drug is not even, the dose, nobody monitors it. So they keep drinking it, and I'm sure it's affecting their system. So it's a good strategy if we can take health education campaign to the villages. Thank you.
Thank you, Dr. Chidema. Mr. Lucas Bruce, it's your turn. Your focus here is on digital health solutions. That is utilizing smartphones, telephone, telemedicine, and data analytics for improved surveillance, diagnosis, and treatment of malaria. Now, in terms of reaching, because if you see the burden of the disease, it's in our communities. And in some of these communities, you actually don't have effective communication system. And so, in terms of reaching remote populations, how can digital health solutions, particularly those not using these gadgets or communication gadgets, be leveraged to improve access to diagnosis, treatment, and education, like you talked about, on malaria prevention modalities.
Okay, thank you very much. Do I have my slides up? Can I have my slides up?
It's a discussion.
Oh, okay. I have a slide, and I was going to show an example of an equipment that helps solve that problem.
Okay.
So the slide is ready. I can do that. If it's not ready, I can just go ahead. Is it ready? Okay. So, in solving the problem of diagnosis, treatment, and access to healthcare in rural areas, first, as someone in technology, the primary thing I do is to take care of, to solve problems using technology. Technology is supposed to make things easier. And so for everything we think of, including meetings, technology is meant to make it easier, including transportation, the same way in healthcare. So in building a company called GeroCare, which you heard about earlier, I worked with a group of doctors and neurologists to build a startup that provide healthcare in the comfort of home for elderly people. And in doing that, we also realized the challenge to healthcare, and we built something called Medra, a telehealth box, which is what I was about to show you on screen. It's just one small briefcase, but it gives you access to doctor anywhere at all for the same cost you have for making a phone call. And that's how we solve the problem of healthcare accessibility. What simply happens is the box is with an administrator, and then anywhere the administrator is with that box, he picks the tablet, he enters your details, and you already have opened the file. From that same box, there's a keyboard inside for him to type in your details. There's a thermometer there. There's a BP monitor there. There are some primary kits. There's also a small kit. You already know how small the kit is for checking the sugar level. So the small kits are within just that one small box that looks like a laptop bag. And the administrator picks your questions, puts in the details, and presses just one button to make a call, and then you can you talk to a doctor, healthcare immediately. And it just goes for the price of a normal phone call. So in combating malaria in rural areas, that simple small box, which technology has given access to, can help people combat malaria in rural areas. Thank you.
All right, thank you very much. That's a novel one. But how are they available? Are they available? You talked about care for the elderly, and you talked about working with doctors, especially urologists, because of prostate issues and all that, prostate care. But we are talking about a particular plague, malaria, which has become endemic in our rural areas. The burden of disease is right there in the communities.
Okay, so
what can be done for those people?
Okay, something we should understand, especially for everyone seated here, is the fact that a computer scientist cannot build a solution to a medical problem. It requires somebody in the medical field to build the solution to a medical problem using technology. So most of the times we see the computer experts, people in the medical field waiting for the computer experts to build the solution to medical problems. And it doesn't happen. So that solution you're looking for about malaria, a tech guy can't build it, but he can partner with a medical person to build it. However, it's always encouraged that people in the medical field also get involved in technology to build that solution. At this very moment, coming from the aspects of technology, we can only have related technology tools that can help in combating malaria. Related, from phone calls that can give them access to doctors, from that's testing, and then we can have call centers, we can have like online orders and distribution of nets or control equipment for that. And then technology can also provide data analytics, collecting data, analyzing that data, doing predictive analysis, in order to tell which area needs this care more and which area needs less, and what are the prevalent issues where a particular area will need malaria treatments more than the other. So these are just tools related to help combat malaria. But in actually combating it and getting to the point of the most minimal impact of malaria in the society, we need the medical guys to come on board to make that happen, and there's no other way to think about it.
All right. In summary, you still talked about intersectoral collaboration.
Yes, collaboration to solve.
Yeah, that's the thing we are all talking about here. Collaboration is key. That's what you've talked about here now. Yeah. So it's a key thing. It's a key message you've given to the medical community here. It's a challenge that we should leave our shores and go into tech. Right now, we're talking about artificial intelligence now. That over time, with the way things are going, so many of our jobs will be taken over by artificial intelligence. And so we need to key in. We shouldn't be in the confines of our labs, our consulting rooms, our pharmaceutical shops, and all that. We should key into technology. That's the thing you talked about here.
Just to add to that, even in the comfort of your consulting room, comfort of your labs, there are problems that you go through every day that technology can solve. In the comfort of your labs as you go to work, there are things technology can solve, but a computer scientist or a software developer cannot come to your lab and solve that problem until you collaborate with someone in that field to produce a technology that solves that problem. So it's necessary to identify the problems and then solve it using tech.
All right, thank you. Dr. Solomon Obonna. Solomon Obonna, okay. This is for you. Your thematic area is standardized monitoring and evaluation, implementing effective measurement framework to track the progress towards malaria elimination goals. Specifically, Dr. Obonna, many regions, our communities, different communities, face challenges that are unique to them in terms of malaria elimination. Dr. Obonna, can you elaborate on how a standard M&E framework can be adapted to account for these variations in our communities, and so ensuring effective measurement of progress towards local elimination goals?
Thank you. In recognizing that there are variants within different regions as malaria, we must first consider the needs. Somebody had mentioned in the first panel, needs assessment. You'd have to understand that the peculiar needs in a particular region is at variance or might be at variance with the needs of another region. For instance, if transmission rate is very high within a particular region, the needs for that particular region will be different from where they're having cases, already established cases. And so, in one region, you are trying to establish primary health facilities that will be able to take care of malaria cases at the lowest level. In another region, you are trying to also distribute, because prevalence rate is high, and you don't want prevalence rate to even move anywhere. If it's moving, it should be moving backward. You'd want to target insecticide-treated nets, distribution of insecticide-treated nets. So we must do a comprehensive needs assessment as to solving the problems of these different regions. We must also look at interregional collaborations. As much as these regions might have differences in their malaria incidence rates and cases and what have you, there might also be similarities. There might also be similarities amongst these regions. And so if a particular region has solved a challenge that came before it occurred in another region, it'd be easier to get the issue resolved as malaria incidents by collaborating with the other region and making sure that you implement the protocols that this other region had also implemented. Amongst other things, key indicators also are part of bed net coverage, how much of the population, all of those indicators are some of the things that we look at in assisting us identify how to approach the variances of malaria cases in different regions. Thank you.
Dr. Bona, when we had the interactive session with the audience, during the first interactive session or first panel session, somebody talked about talking without doing. Some of the things you highlighted here tend towards issues around theoretical framework. Can you tell us practically how can you get that solved? Using this M&E tools, using processes, practical things that can be done. Talk about interregional collaboration. Of course, data is involved here and all that. So how do you effectively do all that?
Unfortunately, I was going to begin by saying everything, almost everything we intend to do as a means of combating malaria revolves around data. I was just waiting to go down to that. Almost everything we are going to do revolves around data. And like my brother, the tech person, had said earlier, there are very user-friendly technologies in place that enables you solve some of these challenges even within regions. Now, there is the GIS technology in place now. You do not need to go to Zambia to say what is your malaria prevalence rate, what was the outbreak cases like, what was the incidence rate, how much nets did you distribute within a particular period. Someone, the focal person for River State, had mentioned about the 23 local government area focal persons. She actually said there were 2 per local government. These people could be at their local government areas and turn out real-time data, where you could be in the River State University Teaching Hospital per day or per hour. You have real-time interface with the malaria cases that has come up. That way also, if that is put in place, and I don't think it's too much of a technology, it's not even that expensive, to help you practically know where the prevalence is high, how to distribute resources and medical kits available, that would help slow down or combat the prevalence in different regions per time.
Dr. Adora Patience Onwoka, yours is during our interactions too, somebody talked about for malaria nation. We move from control to eradication. The point we are now is elimination, possibly towards the 0 point. Now, as a panelist, your area is, you are going to talk to us, is on vector control innovations, considering new technologies and methods for targeting mosquitoes and reducing the transmission rate. Now, your question is this: how can we ensure these vector control innovations are not only effective, but also accessible and implementable in low resource settings? How can we do this?
Thank you very much. I first of all want to stand on the existing protocol. Yes. And I want to thank Eren's Foundation for the good job they're doing. And I want to use the same opportunity to acknowledge the father in my profession, Professor X.D. Abe, who taught me medical microbiology, and all the senior professional colleagues, the pharmaceutical professions and others. So I want to talk about the vector control, innovations, and accessibility to the rural settings. This year theme for malaria, the World Health Organization emphasized the importance of time, the importance of innovations, the importance of investing our time innovations, and to counteract this malaria burden in the rural sectors. And I want to start with the innovations. Before now, we have traditional methods like the use of bed nets, residual indoor spraying, and other interventions that have been used for a long time, and yet we've not been able to eliminate this burden of vectors that are the disease causing malaria. Now we want to talk about new innovations like the recent one called the attractive targeted sugar baits. What is it all about? All this while we've been talking about traditional methods that focus on indoor population of these vectors that, that predispose us to having this disease called malaria. But this time around, Western Innovation Company, they developed this new innovation. They developed the attractive targeted sugar baits. What is it all about? These attractive targeted sugar baits, they incorporate the behavioral aspects of these mosquitoes that love sugar. Mosquitoes feed on sugars on a daily basis. And because of that, they now incorporated a little dose of acid called boric acid and used some scented flowering vegetation and other ingredients to build these bait stations. And it has worked for some studies that was done recently by Fraser et al. 2021. Fraser et al. Did, an elimination study to eliminate malaria, that's the vectors, completely in one rural setting that they studied. And how did he do that? He incorporated the attractive targeted sugar baits, and they mounted them in the rural settings where they have a lot of vegetations. You can agree with me that these vectors, they dwell mainly in bushes where we have tall grasses and where we have a lot of water pools and all that. So they went to such rural settings and mounted these attractive targeted sugar baits to see how it will completely eliminate the high burden of mosquitoes, which are really giving to that rural setting. They now incorporated the scents, the vegetative scents and flowering vegetation that give scents. These scents, what do? They attract the vectors to come to the baits. And when they come to the baits, in their feeding, because they love sugar, the sugar they incorporated engagement, and you involve the elders in the community leaders, and somebody mentioned giving incentives. If you can give incentives to enable them adopt the new innovations they are bringing to them, if you can equally give other things, like if you can give them educational trainings for them to understand how to use this innovation, like attractive, targeted sugar baits. Actually, they can construct their own. We have unrefined sugarcane in our rural settings. We have a lot of things that we can use to fabricate our own local, attractive, targeted sugar baits. And it's cost effective, and not only being cost effective, it can withstand adverse conditions in the rural setting, especially some terrains that are waterlogged, some terrains that are windy, some terrains that a whole lot of things are happening, because there is a new protective membrane covering that guides this, that covers the attractive targeted sugar beets from invasion or being destroyed. And finally, I want to equally say that we need all the stakeholders in the health sector to collaborate with people in the rural area. We don't just sit here and be talking. We need to collaborate with them, maybe on a monthly basis, maybe on a weekly basis, or maybe twice in a month. We should go there and collaborate with them, train them, find out what are their needs. What do they need to make these innovative approaches to work? Because if you don't find out their needs, of course, what we have done may not stand the test of time. And by the time you go there and you have been able to train some people and, give them enough training that will help them to retrain others and to carry out these innovative approaches, I believe it will help us in eliminating the malaria burden by destroying these vectors completely. Thank you.
Wow, this is awesome. It's awesome. I don't know, Aaron's. Will there be a communique for this? And this is something very novel. I wish Dr. Mina was still here. She needs to hear this. These are things, innovative vector control technology. Now, very robust, you've said it, is something that can be done practicably. But the truth is this: how well can we domesticate it in our communities? How can we get it done? How can it be done? Because it's a challenge. So how is it here in River State? Is it being practiced here in River State? If it's not, how can we domesticate it effectively?
Thank you very much. Actually, I've not seen any report or study of the attractive sugar beets in River State that, but I believe that we, the health professionals can as well adopt this new innovation by looking at what it takes. Number one, funding. The funding, if we can get funding from the federal or even the states, for River State state level, if we can get funding, it does not require much money, because what it takes to construct an attractive targeted sugar bait is not much. Once you can get the bait stations, the good bait stations that can stand the test of time, you have your boric acid, which is there with us in most laboratories. You now get your protective membrane to cover the bait station. Then you now get scented flowers. We have some beautiful flowers in River State that when you perceive the scent, they attract. They are called attractants. They attract both pollinators and mosquitoes. And again, sugar, like I said before, mosquitoes, they feed on sugar on a daily basis. They love sugar. And this time around, I'm advocating the use of unrefined sugar cane, because Fraser et al. 2021 used it and it worked for them. So by the time we get unrefined sugar cane and incorporate it as part of the ingredient for the attractive targeted sugar bait, and mount stations in the riverine area, in the malaria high burden areas, and we'll watch. It is specifically for outdoor mosquito population. We are now using it as a comprehensive intervention to, eliminate both outdoor, since we have been using the traditional method, which is the bed nets. All those ones have not been working so well. Let's start from the outside, which is this artificial attractive targeted sugar baits. What they do is complete elimination because of the toxic nature of the acid that were used to prepare it. Once the mosquitoes are attracted, and usually they are attracted in large numbers from studies that people have done on it, when they cluster around the base station, just, in the process of feeding, they are eliminated, because the acid that is being used is very toxic to the vectors. So there is nothing like, the malaria to survive it. If it gets to the base station, it's total elimination. So if we can get, enough funding from the state level to the local level, to the local government level, even as health professionals, we can equally help by doing a collaboration. We'll be mentioning collaboration since morning. We can, collaborate together to go to these, rural settings to mount the stations using our own funds from our different organizations. And again, we have to be sure that there is acceptability by these communities, that they're accepting it. If they're accepting it, it means that the adoption of these innovations will stand the test of time. And how would they accept it? By when they're seeing results that actually, that they're no more having the high malaria burden are reduced drastically. Of course, they will adopt it. Somebody mentioned before that this indoor residual spraying, some people were shying away from it because of some obvious reasons. Some may have some social reasons, some cultural reasons for you not to enter their homes and all that. But this attractive targeted sugar bait has overwhelmed all these, limitations, because it focuses on outdoor population. And by the time you clear your environment, when there's environmental clearing, it then means that to take care of the indoor population is just a walkover. Thank you very much.
Thank you very much. Thank you very much. Wow, it's quite, it's too rich. Quite amazing. And I believe it will not end here. Communicate, especially on this. She's here. You can sort of come up with a proposal to government. Let them try and see the workability of this and domesticate it. They can do trials in some LGs or select some communities, do trials there. And if it's working, then they can make it a statewide thing. So please, it's very important. That's the essence of this brainstorming we're doing here. Now, going back, I'll take one question again, then we'll call it, a close. Now, back to Chidema Azike. You know the current economic realities, the food crisis, food security issues, poverty. Of course, that is things that are characteristic of our communities. Poverty, food crisis. And then we are still talking about malaria transmission. Dr. Chidema, you actually know the link between malnutrition, because if there is food insecurity or food security issues, if there is poverty, of course, No, I'm taking the second one. Now, you know the link between malnutrition, immunity, and malaria transmission. So what strategies, promising strategies, can you use or will you propose to address these interconnected issues?
Thank you once again. Well, there is no way we can talk about malaria transmission without looking at malnutrition and poverty, because they are really closely connected, interconnected. When one is malnourished, you don't have enough to eat, your immunity or immune system will be down. And if your immunity is down, then you see that the output or your production or what you can contribute in the society becomes less, because you will be weak and sick to even work and earn money. So you can see malnutrition, poverty, and malaria transmission, connecting together. Then you ask what we should do, the strategies. If we can improve food security, it will go a long way. And how can we do that? It's important that we start looking at how to encourage the local farmers. Give them small grants to help them. Then even if we can even go as far as government can sponsor mechanized farming to ensure that we have enough to eat. That is one thing. Then we also know that because of economic crisis today, you go to markets with huge amounts of money, you come back home with a nylon bag. You see that you can't even buy enough to eat. That quantity that will be able to give us the appropriate nutrients. So in that case, it's important that we also include in our feeding nutritional supplements. It will go a long way to help us to be strong. Then, apart from increasing or improving the food security, it's important that we pay attention to our environment. Poor sanitation is one of the bane of malaria transmission. If our environment is not clean, we have a lot of gutters with stagnant water and all that. These are breeding sites for mosquito. So if our environment is not clean, then it will be difficult for us to curtail malaria transmission. And when we are infected with malaria, we go down in our immunity. So outside our environment too, through sanitation, it's also important that we pay attention to our waste management. How do we handle the waste we generated? If we don't properly take care of this waste and take them to appropriate site where they're supposed to be, treat them the way they're supposed to be treated and disposed properly, we will continue to encourage breeding sites for mosquito. It's also important that we consider community engagement, as Dr. Adora said. We'll keep talking, keep enlightening people, keep teaching them through seminar activities like this. Tell them that they need to maintain their personal hygiene. Tell them that they need to keep their environment clean. Tell them that they need to feed well. Tell them that it's not about how much you use to cook, but your ability to select the right food. Eat fruits and vegetables to strengthen your immunity. So this enlightenment should be a continuous thing. We should keep doing it until we are sure that everybody out there is aware. So these are some of the strategies we can put in place to ensure that malnutrition and malaria transmission is well tackled. Thank you.
Thank you. Now, there is something quite amazing here, that so many of these products, agricultural products, we have them in our communities. Someone that has okra farm, vegetable farms, small farms, they feed on things you actually need. They are there. There is some, the Ingbe, small things are there. In our communities, the bush meats, every other thing you need, fruits, they're all there. Have you thought of nutrition education as part of health education for our rural population? Some of
will drive many results down to the elimination, eradication, and also improve the lives of people in these coastal communities. Thank you very much.
So we can all see from his narrative, data is key. Data gives us all the information, well-processed data, collected, well-processed data gives us everything we need for planning, strategic planning, and implementation of control programs, implementation of strategies. Everything is centered on good data collection. So as healthcare professionals here, it's key to us. The data, every one of us here have points we must collect data. In the laboratory for our med lab scientists, data is key. For the doctors, not just putting those things, notes on the patient's case notes and you close it. I do a lot of research, a lot. There were some things I needed, studies I was to do. I collected a set of data while trying to get data for a particular study. I saw 2 other things I could deduce from those case files. And that's import of data. I ended up from a study doing 3 studies. So we need to be used to data. We should love data. All these things we are talking about, if we don't have appropriate data, it will forestall any plan at any level. So the next is Dr. Adora, Patience Onwuka. Back to you again. You've told us about the new technology of attractive targeted sugar bath. Fantastic. There are already existing strategies, vector control strategies, which you are aware. One of them is the insecticide-treated nets and a lot of other strategies. Now, my question to you is, how can we integrate the innovative solution you talked about, that's the ATSB, with the traditional methods of vector control? We can't throw them away. So how do we integrate all together?
Thank you very much. Using the word integrations, integration of the vector control methods requires using the traditional methods, combining the traditional methods and the new innovations that, we have discovered. And those traditional methods, like using bed nets, using residual indoor spraying, using insecticides, and mosquito-treated nets, they are all good. But I believe that if there is a comprehensive integration, the traditional methods will address the indoor vector population, while the new innovation like the attractive targeted sugar beets will address the outdoor feeding population. Another thing is community engagement, like I mentioned. The community engagement requires a whole lot. A whole lot. It's not just going to the communities. You have to do a whole lot of, intervention by, addressing it from different points of views. Like, for instance, there is what I call pre-seed. Pre-seed means predisposition of the rural setting. How can we, assess those places, Another one is reinforcement. That is, I call it pre-seed. Reinforcement. The second one is, education, diagnosis, and evaluation. All these are strategies that must be put in place for us to have, a comprehensive, approach using both the traditional and the, new innovative vector control methods. If there is a policy on ground, regulation of those policies, accessibility of the rural settings, that's under predisposition of the terrains where we are going for the, vector control studies or vector control eradication, awareness control. Then we'll now talk about education. You have to educate the community on the importance of vector control, on what it means to have a environmental cleanup, to clear their bushes, those places where these vectors hide. By the time you eliminate their habitats, you've done a whole lot. Then you have to do diagnosis. As medical professionals, that's where the medical laboratory scientist comes in. Do diagnosis of, malaria symptoms to affect actually the symptoms the patient is having is malaria. And by the time the diagnosis is established, you so actualize, because the pre-seed goes a long way to actualize what we have started doing with pre-seed. It's kind of, it's a kind of a conclusive process whereby those strategies is already established and being monitored by some trained medical personnel or some stakeholders in the rural settings. They are there, they are paid to monitor what have been done in the pre-seed aspect because this time around implementation, the stage of implementing these interventions, both the traditional and the new innovative vector control methods. Thank you very much.
Thank you. To Dr. Solomon Obonna. We're still talking about standardized M&E, effective measurement framework to track the progress towards malaria elimination goals. Now, I'll take you up to stakeholder engagement. Now, you are aware that successful malaria elimination requires collaboration. We'll talk about it across various stakeholders. Now, how can an effective M&E framework be designed to foster transparency and communication so as to keep stakeholders engaged and invested in achieving the elimination goals?
Thank you very much. I think that in order to use M&E to involve all stakeholders, like you rightly mentioned when you were asking your question, we must not emphasize this collaboration we are emphasizing over and over at just the implementation stage. We must involve everybody you consider a stakeholder, and that's almost everybody, at the design stage. When they become part of the design, they feel part of it and they want to see it end logically. I was privileged to be in Odohaimova one time. We were doing the RARS program, then under the supervision of Professor Iberi. And we had gone to that community a couple of times, doing what we see on paper, reconnaissance survey, talk to people and all of that. That's not, they were not interested. Until we've devised a means to go talk to people, firstly, they trusted, which included their vigilante chairman. They believe in that community that he has their best interest at heart, home and abroad. So we had to come meet him to say, how do we get the attention of your community people? Because we need to go into their rooms to do RRS then. This is something that we've been trying for weeks, months even. He now asked us to see how we had designed what we were. We just called people in different halls, tell them, malaria at a kilo, come, let's look in, let's pray in your room. He now had to introduce his own idea into the design, which made him give us some of his vigilante boys. The moment they see a vigilante person with you, they open even their kitchen. And the fascinating thing at that time was that we were always very early. So as at 6 a.m., before you even come the following day, they're anticipating your visit. They've moved their kids out of the house, allow everywhere, close their foods, and make it very comfortable for you to do what you want to do. So we cannot overemphasize the importance of allowing stakeholders to be part of the design method. Another thing is that we must have transparency in data collecting and reporting. It's a very big problem for us, especially the reporting part. Because if I'm working with you in collaboration and I feel like you are hoarding data, it discourages me instantly. And of course, I have my own niche.
put our focus on the quality of the anti-malaria that is being distributed in Nigeria. We must put our focus on the incidence of open drug markets in our country. Because when you subject these parasites to subtherapeutic dose of the anti-malaria, learn how to evade that drug. And so the situation where we have open drug market in places like my 1, my 3, it should not be. It should not be at all. Because if the medicine comes out of the factory at good quality, how about the way we move it around? Where is it stored? Where is it exposed? Then, so on and all the rest. The conditions of storage affects the quality of the medicine. One very critical thing is also how do we treat those malaria patients. There is drug that is called artemether lumefantrine. All pharmacists knows that after first dose, 8 hours later, you must give the second dose. But we are putting these drugs alongside tomatoes, vegetables, onions, and what again should I mention? And pepper and okra. All right? And we are treating them as if it doesn't matter, but they are potent chemicals. We are wasting lives and resources each time we subject our medicines to supply chain excursion. So those should be also be in focus. If there's going to be a communique, I would like the communique to reflect the fact that government should put its focus on open drug market and eliminate open drug market from our system. Government should get prepared for the vaccine that is coming because it's already launched in Ghana. In fact, I have a friend of mine whose daughter is always falling sick, and they are thinking of going to Ghana. Actually called a doctor in Ghana to say, look, I want to send my daughter down, look at her condition, and if the vaccine can be given, administer the vaccine, and the daughter will travel back to Nigeria. So it's time for government to prepare for that vaccine as well. So I thank you for the depth of the knowledge. I've gained a lot from this presentation, and I will be looking at that particular solution, the targeted sugar, the bait. I'll be looking at it, and I'll be discussing it within the industry as a whole, because it could be a very cheap alternative to eliminating malaria from our country. So thank you, and God bless you very good. Thank you, thank you. So any other contribution? Okay.
Thank you. Good afternoon, everyone. Thank you so much to the panelists. I really gained from all your sessions. I just want to add to what Dr. Adora talked about, the sugar-based attractants for mosquito vector. I really agree that eliminating the vector of malaria is one key way of combating malaria. And then it brought my mind back to something. It was a device that one of my senior friends talked about. It was a device, and then it was supposed to attract these vectors, mosquitoes. But then he said when he tried to order this device, it was not available to Nigeria. So it goes on to, I would like to say that there are other alternatives too, like there's something called the pheromone attractant. Pheromone attractant. Yes, sometimes I wonder why mosquito bites me a lot. And I know that mosquito is attracted to pheromones that we produce, carbon dioxide and heat. And so there are devices that have been modeled to mimic, with chemicals to mimic these pheromones, or like pheromones that attract these mosquitoes. And I believe that such innovations can be brought down to even the local areas, and then these devices can be powered by solar and all. So it's one way, combined with the other strategies. Together we can combat malaria. Thank you very much.
Well, thank you very much. So we're having new frontiers. Frontiers as it affects research. Research effective research. I will emphasize that word effective. We should be proactive. If we have an effective, proactive research, some of these things are things that we may just hear, like what you said here, heard it here. She's talk about something about it. So those of us that are here that are researchers, are interested in one form of research or the other, these are some forms of concepts. At the point of conceptualization, we should look at all this and get enough literature and then get a direction and see how we can, come up with newer innovations. So we'll take the last speaker.
I want to thank the organizers of this program and also the coordinator of this particular section. I was carefully listening to the discussions, and when Dr. Adora said something about vector control innovations, when she was asked a question, and it occurred to me that actually things have been done in terms of vector control of mosquitoes. And also appreciate the fact that she came up with one new innovation, which I know that for now we are not very familiar with it, which is the activated targeted sugar base. Now, I know involved in when the biolarvicide control was also being carried out. And we also saw that end of the day, it was still not effective. But recently, something has been going on around the world, and we are talking about innovation. And I discovered that there's mosquitoes. There are genetically modified mosquitoes that are available. The role of this, when mosquitoes are genetically modified, in fact, if I can remember very well, one of the major things I got from it was that it's supposed to eat up the natural mosquitoes. And when they eat up the natural mosquitoes or transfer some level of resistance to these natural mosquitoes, we are talking about innovations. And we have things like this around. Have we wondered, somebody talked about the anti-malarials or the drugs not being effective. It doesn't end with that. You can also find out that your insecticides, which you buy, at least I have one in the house. You will spray and spray. At the end of the day, you find out that it does not kill one single mosquito. And sometimes I keep asking myself, I said, is it like these ones have acquired the resistance? Or are they the genetically modified ones? So I think that when we are talking about zero malaria, it is also good for us to really critically examine, are we really working towards a zero malaria? If we are coming up with things like this, that rather than having your medications, your insecticide-treated malaria nets, your larval biocides, and even the attracted targeted sugar sugar base we are talking about now. Yes, it's a goodie. Are we really sincere in getting at zero level? Because if you ask me, I'll also say that even the vaccinations are questionable. So what can we do? I think it's good for us to really sit back of how best to tackle some of these things. I know we are trying, and people are actually coming up with some good innovations that can only help to minimize. Because I see it that what is happening is that all what we are doing is at management level. You come to the point that because you can't eradicate it, let's keep managing it. And I think that we should be able to think in an innovative way to see how to combat these genetically modified mosquitoes. And how do you identify them in the first instance? How can you identify them? I think these are a lot of questions that are begging for answers that we really need to look into. Because most of the times we promote activities, yes, they appear so good on the outside. But if you ask questions and go real deep down, you will see that it's like there is an ulterior motive deep down, that outwardly it is good, but it is not exactly or totally good. So I want us to really look at this and also think on the way forward, because we know that all those things, they are all associated with the debt rate. Thank you.
Thank you. Thank you. It's actually something, she has given us a message to take home. And it's very apt. Now, to conclude, just 1 minute. I'll start with just the last word.
I think my last words on this panel would be the fact that every field is affected by technology, right? And since the architects have learned how to use technology to draw your building plan, and every other field is learning how to use technology to improve service delivery, I would give a charge to lab scientists and pharmacists and people in your industry to also pay attention to using technology to solve some of the problems in your activities in the office. And some of the research work you do should not end up as results of your research, but should be actionable by Professor Zacchaeus Awutu Jeremiah. Your hands together is represented here by his lovely wife, Dr. Teresa Jeremiah. Please let's make our hands together as she makes for this award. Also, an award will be presented to right on Kemel Laifa Omonibeke, and to receive the award is Ambassador Derego. Keme Laifa Monibeke, please come for this award. Thank you. Dr. Teresa Jeremiah, please let's have you receive this award. Anthony Local Government Chairman, Representative, please let's have you also. Thank you. All right, thank you very much. Please do well to present this award for us.
for Honorable Pamela Efa Amonibeke. Your hands together, please. The secretary of this wonderful association, the secretary of the Association of Community Pharmacists of Nigeria. Please, Honorable Maxwell, please come for this award, this certificate of honor. Please. Dr. Joseph Olawuyi, are you here, sir? Dr. Joseph Olawuyi is our special guest. Is he here? He happens to be. He's not here? Okay. All right, so the chairman representative, please, Honorable Maxwell, please let's have you receive this for him. It will interest you to note that the Aaron Sekweku Health Foundation have been greatly supported by the Andoni local government. Actually, that's where I'm from. So I've been pushing our chairman, and he has been a very good man. For the last two Unity Festival, our health foundation happened to be the official medical team for those carnivals. So let's celebrate the chairman. He is a good man. Let's celebrate him now. Thank you. So on behalf of Aaron Sekweku Health Foundation and the ACPN River State Chapter, this is an award of appreciation to the Honorable Chairman, Honorable Erastus C. Award to PhD, GSSRS, JP. Thank you very much, and God bless you.
For the champions, stand up, stand up, stand up. For the champions, for the champions.
Thank you so much. Thank you so much. And yes, I know that I saw some of us refueling, and while we were refueling, I saw some person, and that's the smile we want to see. All right, so I'm just going to do this for formality's sake. Please just ask your neighbor, how are you? And get the response, please. All right, so there's this song, How Are You Doing, My Friend? So let's move a bit. I mean, we've been too serious. You know, usually in school, when we learn, we take a break, Abi. Let's just take 2 minutes break. I mean, we've been learning a lot today. How are you, my friend? You're supposed to sing to your neighbor. Just move your body. Let me see how excited we could be. We'll just do that for just 2 half presentations here. DJ. All right, meanwhile, while we are waiting for that to unwind, rapid check. Rapid check diagnostics, please. We need you for your presentation. Remember, it's just 10 minutes. After rapid check, we have activity pharmaceuticals. Please, we need that. DJ, can we get, is it possible? All right, let's do this for 2 minutes.
More music on trendybeats.com.
For just 2 minutes. Let's see how excited you could be.
Body no vex for me. I never go, you since.
Good, I love the smile. I'll wind up beats just for 2 minutes. Just for 2 minutes. Alright, good. I can see mommy having fun. That is it. Normally, you're supposed to use your phone and picture this exciting moment for yourself.
Make you rest on me. You know I got you. Let me be your friend in need. I'm running on show now. I don't give some time.
I want that excitement.
Nothing's over. Cause anything I get now for me and you.
So, how are you?
My friend. How do you do, my friend? I know sometimes it be like that. Nobody's can do that for me. I'm there for you, my friend. How are you, my friend?
If you want to move your feet, no need to do that. You want to move your body.
I know sometimes it be like that. Nobody's can do that for me. I'm there for you, my friend.
Alright, thank you so much, Nick. You're coming back. Alright, so it's obvious you wanted this. It's obvious you wanted this. Alright, thank you so much. Please, let's put our hands together for rapid check. Rapid check, please. We need you right here. Right after rapid check, we have activity pharmaceuticals. Please, we have just few minutes to do this. Remember, we need to go back online and rejuvenate for tomorrow, so we do not want to waste so much of our time today. So please put your hands together for rapid check. Thank you so much.
Good afternoon, distinguished pharmacists. Please permit me to stand on the already existing protocol. My name is Friday Ama from Rapid Check Diagnostics and Wellness Limited. In the course of this presentation, we'll be looking at, I'll be presenting on optimizing pharmaceutical care via Rapid Check innovative device. In the course of this presentation, we'll be looking at who we are, concept of pharmaceutical care, and point of care testing device from Rapid Check. Rapid Check Diagnostics and Wellness Limited, an indigenous healthcare outfit established in the year 2015. It's a sister company, Test Healthcare Limited, established 2009. Our mission is to be the foremost provider of quality and affordable point of care solution, health screening solution, and innovative medical kit to healthcare system across Africa. And our office is on the screen and also our website. Pharmaceutical care could be defined as the direct responsible provision of medication-related care with the purpose of achieving a definite objective that will improve an health outcome. In order to access this objective, it could be subjective or objective. In the objective phase, involves physical examination of this patient, imaging, laboratory test, and point of care testing. What is point of care testing? Point of care testing is the provision of a test result at the time at which this result will be used to make a decision and also take appropriate action. And the key definition of this definition is that this test is near the patient and the result is used to make a decision and also take appropriate action. This action and decision could be done in a clinic by a healthcare provider or in a pharmacy by a pharmacist or during screening and also done by patients themselves. And the ultimate objective of this is to have an improved health outcome. Now let's look at the three health challenges of our time, which could be called monsters of our time, which could be caged or managed via point of care testing. These three health challenges include diabetes, hypertension, and dyslipidemia. And the basic characteristics of these monsters is that they are chronic in nature. That means they have developed over a period of time, they are not curable, and they affect more people than we can even imagine, and when managed can lead to serious health conditions. These monsters can with the help of point of care testing devices. Now, that brings us to how to monitoring. With what? With other intervention, with our point of care testing device called Keep Track 201, Keep Track blood glucose monitor, palm lab analyzer, and rapid check point of care testing for glycated hemoglobin. Why 201? In order just to refresh our memory, studies have shown that up to 60% of persons living with diabetes also are hypertensive, and also people that are hypertensive may be predisposed to diabetes. With Keep Track 201, monitoring of this disease condition has never been this easy. And it's also worth noting that our Keep Track 201 can be used for just blood pressure monitoring and also for your blood glucose monitoring. That is to say, use it just one stone to kill two birds. This is a device that every family should have in order to monitor their blood pressure or even their blood glucose level. Let's look at some of the key features and benefits of our Keep Track 201. Our Keep Track 201 comes with a very wide curve. As we can see, here this is the curve. It's very wide. It can fit almost all arm sizes. One doesn't need to buy extra curve for one to use for people that have large arm sizes. And also, we also know that for one to get the right measurement, one needs to use the right curve. As you can see, the curve is very wide. You don't have to buy any extra curve for you to test for people that have larger arm. And also, it ensures accuracy of results. Our Keep Track 201 comes with a large much memory capacity. It can store up to 352 test results with date and time. A healthcare provider, you can assess what this patient has been doing, and over time you can know better ways to manage this and have better outcome. Another key feature that comes with our 201 is that it has this alarm setting, 4-alarm setting, that reminds the patient when to run his or her test. It works with you like a friend, making sure that test compliance is ensured. Another feature of our Keep Track 201 is that it has this PC link. A PC link that you can use to download the result of what the patient has been doing over time, and you can have a better overview of the patient management from the PC link. From the using Keep Track software, you can analyze the patient results using different formats that will enable you to have a better overview of the patient outcome. Another feature is that it calls the pre-meal and post-meal setting that helps to keep track of your result in respect to meal time, to either fasting blood sugar, random blood sugar, and other tests like the quality control as well, which is a very important thing that helps to make sure that your result is very accurate. Another feature is that our Keep Track 201 also gives a ketone warning. When one blood glucose level is up to 240 milligram per day, it alerts you of ketone warning, and as such one takes better timely intervention, and also you have a better outcome. There are so many of our features that you can say in Keep Track. Please skip. It comes with AA battery. AA battery is something that you can easily get. It ensures that patients continue to test their blood pressure and your blood glucose level. This is what AA battery is like. So you ensure even those in the rural area, they can make use of this machine and easily get this battery whenever they need to replace it. And our Keep Track 201 also comes with another unique feature that we call the no coding feature. It doesn't require any code. You just need to do it inside the strip, apply your blood sample, and read your results. Testing procedure for Keep Track 201 includes, for blood glucose testing, just inside the strip, apply a blood sample. By capillary action, the instrument will take 0.7 microliter of blood, and in 7 seconds, the result is out. It doesn't require any memo chip, no changing of code, nothing. As in just 7 seconds, your result is out. Then let's look at our Keep Track blood glucose monitor. Keep Track blood glucose monitor. Keep Track blood glucose monitor has similar feature with our Keep Track 201. It doesn't require any code, it doesn't require any memo chip, and also it has this backlight, large LCD backlight that enables people that are diabetic, as we know, have poor vision. Even in the dark, they can use this machine and ensure that they have an accurate result. It also comes with an adjustable unit. With this machine, you don't need to multiply or divide by 18. You just need to set the unit that suits you, either in millimole per liter or milligram per dl, and you read your result directly. And also, it has this unique feature that is also similar to our 201, a PC link that you can download your result and check what the patient has been doing over time. Because of time, please go to PalmLab Analyzer. PalmLab Analyzer is our PalmLab machine that is used for lipid profile testing. It gives you your total cholesterol, triglyceride, low-dose lipoproteins, and the rest of them. PalmLab Analyzer gives you your total cholesterol, triglyceride, your HDL, all the lipid profile parameters in your hand. A PalmLab Analyzer have undergone various certification that makes the results really accurate and reliable. It's a testing device that can make a healthcare practitioner, when a patient comes to visit right there with you, you can test the patient and you can have the lipid result in less than 2 minutes. With our panel analyzer, we say test now, know now, act now. Once you have that result at a pump, it facilitates a healthcare provider to know what to do, immediate treatment option, and drug prescription. With our panel analyzer, because of its small compact size, you don't need to have any more space for it, because it's just a handy machine, just almost the size of this device. It's very small, very handy machine, and also